telepsychiatry is rapidly growing and constantly changing. We have been practicing it since 1959 via standardized, conventional, standalone video equipment, but along with rapid technological advances within the last decade, we were also able to deliver telepsychiatry using personal computers and mobile devices such as smartphones, iPads, laptops, all of which have built-in camcorders and installed video platforms or video software. Unfortunately, regulatory constraints in combination with clinicians' concerns have kept telepsychiatry from being widely adopted and implemented prior to the current COVID-19 pandemic. Accordingly, the pandemic time for the vast majority of clinicians is the first time they use telepsychiatry, and very few have received training in how to do it. Some colleagues may have found readily available guidelines from primarily the United States, Canada, Australia, and recent excellent guidelines from colleagues in India. These documents are for sure relevant and useful. So one may ask, why do we need another set of guidelines such as WPA's global guidelines for telepsychiatry? As telepsychiatry is neither widely adopted nor established, especially in low and middle income countries, this document aims to outline universal guidelines that apply regardless of local or regional regulations. We trust that it will be a useful source of information for practitioners, policymakers, and communities. But one may ask, what is so new and special by this set of guidelines? Well, compared to all existing similar documents, this one opens the door to the discussion of some new and previously undiscussed aspects of telepsychiatry. Aspects that are capable of changing the whole delivery of mental health care that we have known so far. The first important aspect is cross-cultural telepsychiatry model, which I have invented and launched 20 years ago in Denmark. Cross-cultural patients' mental health care requires high standard of communication between the patient and the provider, as linguistic, cultural, and even racial differences can affect the quality of care and patient satisfaction. The majority of ethnic minorities access assessment and treatment through interpreters. Therefore, I suggested that bilingual clinicians use telepsychiatry service to assess and treat refugees and migrants in Denmark so that the need for interpreters can be diminished or even eliminated. This is now known as the telepsychiatry ethnic matching model that could be particularly useful in current refugee crisis in European Union. Unfortunately, bilingual clinicians are sometimes not readily available within country borders. In such a situation, we must ask for help from our colleagues abroad. And this leads us to the second important news that has never been elaborated in other telepsychiatry guidelines. It is international telepsychiatry, which may be used to get a qualified second opinion from colleagues with a relevant cultural and linguistic background. In addition, international expertise can be brought via telepsychiatry to local health workers as part of education, supervision, and scientific collaboration. Internationally recognized experts can be just a click away. Technology knows no geographical barriers. It is us who create barriers and boundaries, and it is us, humans, who who are entitled to remove them as well. So let's look at the barriers and possible solution recommendations outlined in WPA's global guidelines for telepsychiatry and addressed to 3 different sites: video equipment manufacturers, telepsychiatry clinicians, and policy makers. Related to the video equipment, we experienced during the pandemic widespread use of tools such as Viber, Skype, WhatsApp for telepsychiatry in patients' own home. These tools are affordable and widely adopted. However, it is important to ensure privacy and data security under telepsychiatry appointments. That is why WPA Global Guidelines for Telepsychiatry come with a few recommendations to video equipment producers. The first one is to improve data and patient safety features of currently unsafe but widely adopted applications. The second one is to increase interoperability and intercompatibility of the video tools in general. It will enable increased collaboration across boundaries of each specific video equipment brand and type of equipment, whether it is standalone video or video platforms and softwares within mobile devices. In the scientific literature describing telepsychiatry during COVID-19 time, we could read statements that require clarifications, which we have given in our guidelines. The first such statement is that paranoid patients are not suitable for telepsychiatry. This may sound logical, but logic is not always congruent with the real life. If paranoid patient, as well as any other, get proper and easy to understand information about telepsychiatry, then the risk for paranoia related to video camera will be significantly diminished. Clear and easy to understand spoken and written information about telepsychiatry before the start of the remote assessment and treatment is crucial and can prevent potential paranoid ideas. The second prejudice is that elderly people are not suitable for telepsychiatry due to their digital illiteracy. Well, the statement is only true for elderly, cognitively impaired patients who are still living alone. When elderly are placed in nursing homes, they do not have to operate with the tool. It is done by the nurses or other personnel on site. The most common prejudice related to telepsychiatry is that the body language cannot be read on distance. Loose-fitting clothes indicating weight loss and gait abnormalities are all examples of integral pieces of information that are lost with the use of telepsychiatry. This is a citation from recent scientific article. Such perceptions are valid only when speaking about telepsychiatry provided via mobile devices to the patients at home, as the majority of patients do not have standalone video equipment that could be remote controlled. On the other hand, mobile devices with built-in camcorders such as smartphones, iPads, laptops or home computers with standard external webcams do not allow pan, tilt and zoom functions and logically reduce the ability to read the body language. When the telepsychiatry is provided between 2 clinically supervised settings, for example, between a general practice where the patient visits his doctor and the psychiatric hospital or private clinic where the psychiatrist is located, then it is usually done via standalone equipment. Clinicians must be aware of differences between the video tools used for remote consultations, as well as respective differences within clinical settings. This short clip was recorded 20 years ago and demonstrates telepsychiatry at its best. When we learn how to use standalone equipment, we can even read body language much more easily than in person. We can see the patient entering the consultation room, get closer to the patient when he is far away than we could in the same room. We can predict if the patient is about to cry, as we can zoom in a few centimeters from the patient's eyes without him noticing. The benefits of increased access to remote services are apparent for telepsychiatry, but benefits can only be realized if the tools are used by clinicians who have the appropriate training and guidance related to the selection of video tools as well as their proper use. Clinicians must develop the relevant skills and competencies needed to perform assessment and treatments using a wide range of video conferencing equipment, each with different features and related benefits and limitations. Therefore, competency training in digital mental health is the priority number one and the major recommendation addressed to the clinicians within WPA's global guidelines for telepsychiatry. Very important news that we deal with is related to regulatory issues and its potential globalization. Under current required licensing laws, it is common for the patient not to be treated if he or she is not located within the same country boundaries as the psychiatrist. Many patients who already see the psychiatrist may be exposed to significant disruption of care in the case of travel, work, or study abroad, as they would either be forced to see another professional licensed in the respective new country or not see anyone at all. Within the guidelines, we discuss a recent phenomenon called the meeting in the cloud. It's technically where we meet our patients while delivering remote internet-based consultations. The location of the cloud is determined by the location of the internet server, not by the physical location of either the patient or the professional. Conceptualization of the visit up in the cloud then may cause future changes in existing regulations. This momentum poses new challenges for licensing authorities and calls for international cooperation between policymakers. That is why we recommend and encourage policymakers to start work on creating uniform licensing rules, first regional and then global. This is crucial as the regulatory constraints still pose significant barriers to wider use of telepsychiatry in a globalized world. Current local regulations make it difficult for many to receive needed care that otherwise would be possible thanks to the technology. At the same time, free movement around the globe as well as free choice of healthcare providers are undeniable human rights. Some of us are lucky enough to take such basic things for granted, while being aware of inequality in access to care for the following patient populations. Refugees and migrants. They have the right to receive care similar to that received by national citizens, which means on their mother tongue without the use of interpreters. Physically impaired and elderly people have the right to care in the privacy of their own home or respective housing institutions. People who avoid transportation due to phobia have the right to remote treatment. For them, in-person consultation is associated with a number of obstacles, unless the therapist visits the patient, which is not so likely in real life. The following video demonstrates some of the difficulties that agoraphobic patient may experience daily. Stigmatized people have the right to receive care without being seen in the environment to which they are stigmatized. People within the autism spectrum usually experience difficulties related to physical proximity. Available research confirms the reliability and effectiveness of telepsychiatric assessment and treatment of the autism spectrum. Such persons have the right to be seen remotely if they prefer. Therefore, the greatest importance is increased understanding of the patient's needs on one hand and the roles of professionals on the other. I'm sure the professionals are aware of the patient's needs. However, we must remind policymakers. We hope that the guidelines will pave the way for improved international collaboration, not only by clinicians but also by policymakers, and inspire them to take a step towards unifying rules and global regulations in order to break down the barriers of accessibility for the professionals as well as for the patients worldwide. Mental health care without borders may not be a mission impossible anymore. Global teamwork is the light at the end of the tunnel of current and future global crises. Now is the time for us, through our united efforts, to build on a new user-friendly digital mental health care system that can better meet the inevitable future challenges. For we must not return to where we have been yesterday. We hope that WPA's global guidelines for telepsychiatry can help us to move forward. Thank you for your attention.